So we're going to move on to Dr. Sozio. Margaret Sozio has been a IU hepatologist here since 2008. She has a special interest in the gender discrepancies that we observe in some of the chronic liver diseases. Therefore, she's really the perfect presenter for this talk, which is entitled Women's Health in Pregnancy in Autoimmune Hepatitis. Thanks, Dr. Sozio.
Oh, that's the time. Okay. Craig.
Right there. And there's always a pointer if you need it.
Okay. Okay. As Dr. Lambert said, we're going to be discussing women's health and pregnancy and autoimmune hepatitis. Our aims today are to understand the effects of autoimmune hepatitis on women and on their fertility, to explore the effects of autoimmune hepatitis on pregnancy outcomes, and finally to understand the risks and benefits of immunosuppression, both during pregnancy and breastfeeding. Autoimmune hepatitis is more common in women. It's about 3.5 to 4 times more common. We think the susceptibility may be due to a combination of genetics within the environment of sex hormones. So we actually know that sex hormones can affect the immune system. It can regulate gene expression, which leads to which proteins are produced. It can alter the presentation of protein particles to the immune system, either presenting it in an activating factor or in a suppressing factor. And it can alter the cytokine environment, which can either be pro-inflammatory or anti-inflammatory. There was a study in 2002 that looked at the outcomes of autoimmune hepatitis in women as compared to men. And they did find that women were more likely to present with other autoimmune diseases, about 34% in women versus 17% in men. These are things like autoimmune thyroid problems, celiac disease, even ulcerative colitis. However, otherwise the outcomes in men and women were similar. The age of diagnosis was similar, the severity of disease and the presence of cirrhosis was similar, and treatment outcomes. So we really don't manage women any differently than men, other than maybe having a heightened awareness for other autoimmune disorders occurring concurrently. However, women have the unique ability to become pregnant and bear children. So this does lead to unique managing issues with women. Fertility is defined as the ability to conceive. We do know that this can be decreased in cirrhosis. Many women with cirrhosis do not ovulate and do not menstruate, though not all. Older studies looking at autoimmune hepatitis in women found decreased fertility. There was a study that was published in the 1970s, and the data was collected from the 50s to 70s, so very old. And they looked at 37 women over that time period and found that 16 became pregnant. Compared to a control group of 37 women, they found that that fertility rate was lower, and determined that fertility was decreased in women with autoimmune hepatitis. However, there are some limitations. This is an old study, and they were probably including women with other disorders other than autoimmune hepatitis. They also didn't have a lot of information on contraception, which obviously is important to know. And treatment outcomes are very different. You know, we have a lot more understanding of how to manage autoimmune hepatitis now compared to in the 1950s to 70s. There was a study out of Sweden where they actually sent surveys to women. This was a more recent study. And they asked women if they had wanted to become pregnant and were unable to do so. About 10% answered yes to this question, and this is higher than our national average, at least of 6%. However, there are certainly biases with this as well. Recall bias is present in surveys, and we don't have a validation really truly showing that these women had impaired fertility. We do also know that in other autoimmune disorders, fertility is decreased. So there probably is some decreased fertility, but on the other hand, we know that women with autoimmune hepatitis can go on to become pregnant and have successful pregnancies. Well, what about in vitro fertilization with autoimmune hepatitis? There's not a lot of data out there. There were some case reports of women with autoimmune hepatitis who used in vitro fertilization to become pregnant. There were 4 conceptions in 3 women without cirrhosis. 2 of these resulted in healthy conceptions with healthy mothers. The 3rd mother actually developed autoimmune hepatitis after undergoing in vitro fertilization, and her first child was born with cerebral palsy. The 2nd pregnancy resulted in premature delivery with fetal loss. There were 3 conceptions in 2 women with cirrhosis. One of them resulted in a healthy baby, but the mother's disease worsened, and the others 2 led to miscarriages. Well, what about contraception use in women with autoimmune hepatitis? This is important because we know that estrogen-based contraception can have an effect on the liver. It can lead, or it has a risk, I should say, of cholestasis, which is where the liver is not processing the bile salts like it should. And we know that the form of estrogen-based contraception does not change its effect on the liver. We do, however, know that progesterone-based contraception has minimal, if any, effect on the liver. So in 2009, the World Health Organization came out with recommendations on how to manage contraception in women with chronic liver disease. This was not specific to autoimmune hepatitis, but certainly is applicable. And they found that women with chronic liver disease, and even those with early cirrhosis, any of these contraceptive agents were safe to use. However, in women who had an active flare, who were not already on any contraceptive agent, the combination contraceptive, which are the ones that contain the estrogen, should not be started. They felt that the risk was too high. If women were already on combination contraception and developed a flare, they felt like it was probably safe to continue it at that point in time. However, if a woman has severe cirrhosis, and this is what we call the decompensated cirrhosis, as other people have described, actually none of these contraceptive agents are safe to use except for maybe the copper IUD. As we had mentioned, though, oftentimes these women are not fertile. So our take-home points for fertility in autoimmune hepatitis is that fertility in women with autoimmune hepatitis probably is slightly decreased. We really don't know to what extent, but we do know that many women with autoimmune hepatitis achieve successful conception. In vitro fertilization may be an option. We just don't have enough data, but I would caution about its use in cirrhosis, and we'll discuss that a little bit more later. And hormonal contraception can be used in women with stable disease. Now we'll move on to pregnancy and autoimmune hepatitis. I've listed here the 4 major studies in the past 30 years looking at autoimmune hepatitis with pregnancy. You can see there's not a lot of data out there. There were 188 pregnancies in 119 women over this time period. 3 out of the 4 studies were retrospective, which means they went back and looked at data. The 3rd study here, Buchel et al., actually was just a compilation of case reports, so 5 women with 14 pregnancies, but I included it because there just isn't a whole lot of data. So unfortunately, pregnancy does come with a risk of maternal death, even in a healthy mother. And here you can see that there were 5 maternal deaths out of 119 women, and this translated to a risk of about 4%, much higher than the US average. Now, I will say that this is probably skewed a little bit more to the higher end. Part of that is because the largest study, this first one, Westbrook et al., that had 4 maternal deaths, collected data from the 1980s to 2009, and certainly our management of autoimmune hepatitis, but also our management of cirrhosis complications and even liver transplant have all improved over the years. So this may be skewed a little bit more to the higher end. For severe complication rate, and this is liver-related or non-liver related, the risk averaged out to about 8%, and in the general population, it was about 1.5%. We also know that there is a risk of developing decompensation during pregnancy, or even going on to require a transplant either during pregnancy or in the year after. And that risk was about 5.3%. They saw 10 women who had either of these problems. We do know that cirrhosis increases the likelihood of having an adverse outcome during pregnancy. Here you can see that these studies contained a large number of women with cirrhosis, about half. The maternal death rate, 3 out of the 5 maternal deaths occurred in women with cirrhosis. And this accumulated into a risk of 5.5% of death in women with cirrhosis compared to 3% if the woman did not have cirrhosis. The severe complication rate was also much higher. You can say anywhere from 30 to 80% of the severe complications occurred in women with cirrhosis. This translated to a risk of 18.5% of having a severe complication if the woman had cirrhosis and autoimmune hepatitis, compared to about 10% if cirrhosis was not present. I want to move on to the risk of flare during pregnancy. This is a serious issue, and as you can see, it's actually very common. There's about, on average, a 50% chance of a woman having a flare either during pregnancy or in the postpartum time period. It ranges anywhere from 33 to 86%. This is important for a few reasons. The first is that it can precipitate hepatic decompensation, so it certainly can lead to worse outcomes in the mother. It also increases the likelihood of neonatal ICU admission, or translating to worse outcomes in the baby as well. During pregnancy, the disease activity of autoimmune hepatitis oftentimes improves. Pregnancy is an immune-tolerant state, so the disease activity of autoimmune hepatitis decreases because the mother's body is suppressing the immune system to allow the fetus to grow. Some physicians will use this as a reason to adjust the medication. Some physicians advocate either decreasing immunosuppression as much as possible or even switching over to different immunosuppressives. However, some of these studies had found that the risk of flare actually may increase if the medicines are adjusted during this time period. The risk of flare is highest postpartum. One study found that 20 out of 26 flares occurred postpartum. We know that this risk seems to be highest in the first 3 months, though it does probably extend out even farther than that. And that means that if medications were reduced or adjusted during pregnancy, they need to be ramped back up prior to delivery, if possible, a few weeks prior. It also means that postpartum, the mother's liver tests need to be monitored pretty closely, so I would say every 2 to 3 weeks. One of the studies found that there were some risks associated with a flare. The first was if the mother's disease was not well controlled in the year prior to conception. You can see that afforded a 48% risk of flare versus 23% if the risk was, or if the disease was well controlled. If the mother was completely off therapy, that also increased her risk of having a flare. It doubled it. Finally, they found an older age at conception increased the risk of flare as well. So they found that women, on average, 29 years versus 26 years were more likely to have a flare. I mentioned the second one there, or this last one, showing a possible association with autoantibodies. This was in one study, and they found that if a woman had the soluble liver antigen antibody or the Rho-SSA, she had a higher risk of flare, but this has not been validated. Fetal outcomes actually are pretty good overall in autoimmune hepatitis. You can see here the average live birth rate was 75%. The CDC lists a live birth rate of 65% in the United States, though this is including induced abortion, so our true live birth rate is probably higher in the general population. The miscarriage rate on average was 15%, which isn't too different from the US average. The fetal stillbirth rate was actually lower on average here, though they ranged up to 7%. Prematurity, however, was more likely. And so you can see the prematurity rate in autoimmune hepatitis was 18% versus 11% in the US. Again, cirrhosis increases the risk to the fetus as well as the mother. So the live birth rate in women with cirrhosis was 57% versus 83% if a woman did not have cirrhosis. Prematurity was also more likely, 26% versus 17%. And the need for neonatal ICU, 21% in women with cirrhosis versus 5% without. However, overall, the congenital malformations were no different in women with autoimmune hepatitis versus those in the general population. The average gestation was normal, and the average weight was normal as well. So we know for factors that increase the risk in pregnancy with autoimmune hepatitis, again, just in general, poor disease control in the year prior to conception increases overall any adverse events during pregnancy. The absence of therapy also makes it more likely to have an adverse event, increased maternal age, and of course, cirrhosis. Our take-home points here are that pregnancies in women with autoimmune hepatitis are higher risk than average, but in general, the risk is not prohibitive. Autoimmune hepatitis increases the risk of fetal prematurity, but outcomes overall are positive. The risk for both mother and baby is higher in cirrhosis, and that flares occur often, particularly postpartum, but optimal disease control can lessen the risk, and this will be important as we move on to medication management for autoimmune hepatitis during pregnancy and postpartum. I wanted to briefly explain what the FDA pregnancy categories are. So this is a category that the FDA gives to medications when they're used during pregnancy. And it can range anywhere from a category A, which means there are a number of studies in women showing no adverse events to the fetus, all the way down to category X, which means you would never use it in pregnancy. And you can see most of the medications that we use in autoimmune hepatitis are listed as either category C or D. C means that there are animal studies, but we don't really have a lot of data in humans showing adverse events. And then D says that there are adverse events in humans, but that sometimes the medicine still should be used. So azathioprine is listed as category D, but I'm going to talk a lot more about this in the next few slides. There's a lot of data actually showing that it's very safe to use during pregnancy. Mycophenolate mofetil is also CellCept. There have been a number of reports coming out showing that there's an increased birth defect rate in women who use this, 23% versus 4 to 5% in similar patients. And so the FDA has come out and said not to use this during pregnancy. And if women are taking mycophenolate mofetil and are in their childbearing years, they need to be on 2 forms of birth control. Tacrolimus is level C. Animal studies had showed increased fetal loss and malformations, but they use much higher doses. In humans, they really have only found low birth rate and preterm delivery, so we go ahead and use it. Prednisone is category C, which I think is interesting because we use that in pregnancy for a number of different issues, and certainly if a woman were to have a flare, that would be our mainstay of treatment. In humans, it's really only shown premature rupture of membranes, which can translate to premature delivery, and adrenal insufficiency. Sirolimus is a category C. This has been shown to have increased fetal loss in animals, but it doesn't appear to have an increased risk in humans, though I don't think we have a lot of data. So specific to azathioprine, this is probably our mainstay of treatment for autoimmune hepatitis. We do know that it can pass through the placenta, so they've found actually metabolites, the ones that specifically decrease cell counts in the fetus. It has been associated with low white blood cell counts in infants, anemia, and thymic hypoplasia. However, there's a large amount of data out there, thankfully, showing that it's safe to use in pregnancy. A lot of the data comes from the inflammatory bowel disease population. And overall, those studies have shown no increased risk of prematurity, fetal loss, or congenital malformations with using azathioprine. There's one study with 86 patients on azathioprine, 84 patients on other immunosuppressants, and 45 who weren't on any therapy. And again, they found no difference in congenital defects, prematurity, live births, or birth weight. There is actually also a large ongoing prospective trial that has not yet been completed, but to date has not shown any adverse events. So we do feel that azathioprine is safe to use in pregnancy. And as we had mentioned before, we really want to decrease the likelihood of a woman having a flare. So that's helpful that we can use it. Specific to autoimmune hepatitis, there's not a lot of data out there. But in the studies that have looked at it, they've found no difference in miscarriage rate or in live birth rate. And similarly, we had mentioned that there's no increased congenital malformations either. We do, however, know that treatment decreases the risk of flare. In women on azathioprine, they had a 21% chance of flare versus 50% if they weren't on treatment. And as I had mentioned earlier, some physicians have advocated switching from azathioprine over to prednisone-based therapy, but we know that there is the potential of a flare with doing so. So our options for medication management, and this is something that you're going to have to come to a decision that you feel comfortable with as well as your doctor. But the options are to either continue the medications. We do have significant data that medications are low risk. We know that the risk of flare is higher with stopping the medications. And we know that flares can be difficult to treat once they happen and can lead to worse maternal and fetal outcomes. The second option is to change the medications, either to decrease the immunosuppression or to switch over more to prednisone-based therapy. But we know that there's a risk of flare with switching medications early in pregnancy, and there's really no data showing that the outcomes are better with this approach. The last option would be to stop all medications. We at least know that pregnancy lowers the risk of flare, but we also know that that increases the risk of flare postpartum, as well as during pregnancy if you're not on any medications, and the outcomes may be worse. So in my patients, I recommend that we continue their medications. As far as breastfeeding with immunosuppression, azathioprine actually is also felt to be safe. Less than 1% of the dose makes it into the breast milk. There are no detectable levels in the infant's blood, and there was a long-term study that followed children up to 6 years out from birth and found no adverse events in those children. Prednisone, you can see a very small amount gets into the breast milk, and we also feel that that is okay to continue. For tacrolimus, there are a number of studies showing that a very small amount gets absorbed by the infant. However, there aren't any long-term data on children who are exposed during breastfeeding, but overall we feel that it is safe to continue. On mycophenolate mofetil, there's no studies, and it's not recommended to do this. And on sirolimus, there really isn't data, so at this time, we're not recommending to continue it if you are breastfeeding. So our take-home points here are that the majority of immunosuppressives have minimal risk to the baby during pregnancy and breastfeeding, and that continuing medications during pregnancy leads to decreased flares of autoimmune hepatitis and better outcomes for the mother and baby. Our conclusions today are that women with autoimmune hepatitis are more likely to have associated autoimmune disorders, but outcomes are similar to men. A successful pregnancy is possible and even likely in women with autoimmune hepatitis with appropriate management, and that many immunosuppressive medications can be safely continued during pregnancy and breastfeeding and can improve outcomes in the mother and child. Thank you.